Come back after the summer to Monty Hart. It's really great getting these lectures going again, and we're lucky to continue to have fantastic faculty who come and join us. And we invite you as always to continue asking your questions, either raise a hand or via the chat function, and we'll try and answer them. So very lucky today to have a good friend from São Paulo, Brazil, Pedro Lemos, who's going to talk to us about P2Y12 inhibition. And I think it's something we almost take for granted. We're always talking about techniques and devices. So I'm glad we're getting back to a bit of pharmacology. Pedro, thank you for taking the time out to join us. We really appreciate your time and your expertise.
Thank you, Azim. It's a pleasure to be here. Thanks for the chance. I also work at a university and a hospital called Albert Einstein, so we share the same name. Happy to be here. As you said, P2Y12 inhibitor monotherapy after PCI, that's something I'll try to show to you today. That it's something that's coming. That's coming. I don't have any conflicts for this talk. Well, let me just give you the current recommendation. It's class 1 recommendation according to the last guideline for coronary revascularization, just published this year, beginning of this year. Those are the American guidelines. After PCI, either if you have stable coronary disease or ACS, if you receive a DES, you will have to, it's recommended to use DAPT, meaning aspirin plus clopidogrel, or aspirin plus clopidogrel, or prasugrel, or ticagrelor for at least 6 months. 1 year for patients with ACS, and at least 6 months for patients with stable coronary disease. Now, when you look at these recommendations, class 1 recommendations, those are the same recommendations so at least 6 months of DAPT for everybody. When you look at these recommendations, that's more or less the same recommendations ever. This is the same recommendation. This is the same figure that appears in the 2016 guidelines of the same societies. Nothing changed. Well, it's never too much to remember that the things that we do right now in the cath lab in terms of coronary stenting are different from the things in the early phase of DES. The stents that we use right now are certainly less thrombogenic. We do have less MI after PCI with the technology that we have right now. And we also learn, as in over the last years, that having a bleeding event is very harmful. When you look at this table, and this is just one study that I bring to you, but I mean, there are so many other studies showing the same thing. This is the mortality, 2-year mortality. So this is not a combined event, it's death after an event, either a bleeding event or an MI. And the impact of having a bleeding event or an MI after PCI in the death rate after this event. Now, when you compare the chances of dying after a bleeding event in the 2 years after the event, it increased in 5 times the mortality as compared to those who had not had a bleeding event. Of course, having a new MI is not good, but it changes and increases the chances of mortality in only 2 times. So according to several studies, and this is just one, having a bleeding event, a major bleeding event, is worse than having a ischemic event. And DAPT decreases, and that's the rationale of using it, ischemic event, but it increases bleeding event. Now, when you look at the pharmacology of these agents, it's always good to come back to the bench and see what we are doing when we give a pill to the patients. This is the plasma of healthy volunteers. We measure the aggregation of platelets following several stimuli, arachidonic acid, ADP, collagen, adrenaline, for instance. And this is a control vehicle, nothing added to the healthy volunteer, the plasma of healthy volunteers. When you look at the effect of the stimuli with the vehicle only, the aggregation of the platelet increases following, any stimuli. Now, when you add aspirin to these experiments, you will see that there is a decrease in aggregation after some stimuli here and here, but not in others. Not in others. When you give prasugrel, there is a decrease following basically all stimuli here, 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 and here. And what about DAPT? What's the effect of adding aspirin to prasugrel or vice versa? Now, when you look at the, and this is in vitro, when you look at the effect of platelet aggregation of DAPT with prasugrel plus aspirin, there is no additional effect of aspirin as compared to prasugrel only. Now, this is in vitro for healthy volunteers. And what about patients? This is a randomized trial. Patients were randomized ticagrelor plus aspirin, so DAPT with ticagrelor versus ticagrelor with no aspirin. And blood samples in some time points here. So this is ex vivo. And again, there is no additional effect of aspirin when added to ticagrelor in terms of the aggregation of platelets according to several stimuli. Now, the question that's posed to us is the following. I mean, if aspirin does not seem to increase anti-platelet aggregation effect, do we really need it after PCI, especially in a time that we have right now where stents are less thrombogenic? In other words, what about testing a monotherapy antiplatelet scheme with only P2Y12 inhibitors, aspirin-free? Now, that has been tested in some studies actually now. The first one was the global leaders. As you see here, 16,000 patients randomized to DAPT only 1 month and then ticagrelor monotherapy versus DAPT for 12 months. Those patients were followed up for 2 years. And what you see here is that this study was designed to be a superiority study, didn't reach superiority, but it was clear non-inferior to take aspirin out. Next study, 2019, the Twilight, patients were kept on DAPT for 3 months and then randomized to ticagrelor monotherapy versus DAPT. The results are known to everybody. Ticagrelor monotherapy was associated with less events, basically less bleeding, while maintaining the same anti-ischemic effect protection. Next study, JAMA 2019, Stop DAPT2, more or less the same concept, 1 month DAPT, basically with clopidogrel, different agent now, versus conventional DAPT. ACS and stable patients included here, here, and here. Again, the same result. Monotherapy was better than DAPT for the first year of follow-up. Another study, 2019, everything very recent, JAMA, Smart Choice, same thing. 3 month DAPT and then clopidogrel only no aspirin versus conventional DAPT. Non-inferiority trial, very clearly a positive trial. Taking out aspirin did not decrease the efficacy or change the safety of these patients. Next study, 2020, JAMA TICO trial, 3,000 patients, ticagrelor 1 year DAPT versus monotherapy after 3 months of DAPT. Similar results. The study was designed to be what we saw here was superiority. Ticagrelor monotherapy was better than DAPT, and basically because it decreased again bleeding while maintaining the same protection in terms of ischemic events. Master DAPT just published 1 year ago, less than 1 year ago. That was a different, little bit different. Only patients at high bleeding risk were randomized, but again, DAPT very short, 1 month, and then monotherapy basically with clopidogrel versus standard DAPT. Similar results, similar protection in terms of ischemic events, less bleeding. And the last study, STOP-DAPT2 ACS, just published this year, in April this year, JAMA Cardiology again. This study was designed to be a non-inferiority trial. The monotherapy didn't reach non-inferiority, but almost. And the funny thing here is that this is a pure clopidogrel study. Now, when you look at this study, I mean, there is a lot of randomized trials already concluded with several thousands of patients randomized. There is some gap of information, as you can see here. Basically, what was tested was clopidogrel mono, mainly clopidogrel mono, or ticagrelor. And another important thing is that all trials gave at least 1 month of DAPT, some of them 3 months of DAPT. There is a lot of many other randomized trials on the same topic running right now. All of them will give at least some time of DAPT. There is only one trial, the Mindset, that begins to give monotherapy just after PCI, aspirin-free, no DAPT whatsoever after PCI. That happened to be a study that we are conducting. I give you the details of this study. This is a single blinded study. It's not a placebo study. More than 40 sites in Brazil. Actually, right now we have 45 sites, including across the country, as you'll see in the next slide. Only SCS patients are included, and they have to be high risk unstable angina or ST elevation MI or ST elevation MI. They had to be admitted in the hospital in the first 24 hours of the event to be eligible. And randomization must occur in the next 96 hours after admission. All lesions had to be treated already, culprit and non-culprit. Sorry. And if so, the patient is then randomized. And the randomization is the following: 3,400 patients randomized 1:1. DAPT, aspirin, plus ticagrelor or prasugrel, and the choice here is left to the investigator, the local investigator. The local investigator chooses which agent will be used, and have to stick to this agent till the end of the follow-up. So DAPT, 1,700 patients versus monotherapy, ticagrelor or prasugrel. Now, before randomizing, the investigator has to choose the agent. So the randomization here is actually not to DAPT or mono, is to take out or not aspirin. Patients are followed up for 12 months. Primary endpoint, 2 primary endpoints will be tested. Ischemic key endpoint, which is it's a composite of death, stroke, MI, or TVR, and that's going to be tested for non-inferiority. And we also will test bleeding events, BARC 2, 3, or 5. That's going to be a superiority hypothesis. We have already included almost 2,000 patients. As you can see here, it's a Brazilian study all over the country. International committee, as you can see here, people very active in the field, Marco Valdemili and the friend Dominique Angelillo, Patrick Serraus, and all these guys have been working in the field for so many years. Now, I think that the inclusion will be finished by the end of this year. So the last patient in, the last patient out, we may be able to show the results in 1.5 years from now. Now, one last question that people may be interested is the following. I mean, if you use monotherapy with P2Y12 inhibitors for the first 12 months, after that, what should I do? Because I mean, life doesn't finish in 12 months. So, what to do after that? Should I come back to aspirin? Should I keep the same agent? This is a question still open to be answered, but there are two studies, very interesting study that shows, or at least seems to show, that most probably we'll have to test aspirin versus P2Y12 after 12 months. And most possibly, what this trial shows is that P2Y12, even after 12 months, are better than aspirin alone. They keep the same protection in terms of ischemic events while decreasing bleeding, as you can see here in this study, which is the host exam study, and the sub-study of the global leader, because the global leader followed up the patients for 2 years. Because of the conjoint of evidence that I've just shown to you, already published, the class 1 recommendation of the last guideline of ACC, AJ, and SKY didn't change in terms of class 1, but the class 2A did change to include a possible discontinuation as a 2A recommendation, a possible discontinuation of aspirin after 3 months, and P2Y12 monotherapy after that, if you receive a DS stent, either if you have ACS or stable patient. So in conclusion, Zim, aspirin-free therapy with only P2Y12 inhibitors after PCI do seem to be promising as a strategy, and it's rapidly accumulating evidence is showing that it's safe and efficacious to do that. There are some several open issues that have to be answered regarding the best timing and the best agent to use with monotherapy. But there are so many randomized trials going on right now that very shortly we'll have some of these questions answered. Thank you, Azim.
Thank you, Pedro. That was excellent, phenomenal. I thank you so much for doing that, and again for, I guess, stimulating us to rethink the way we're doing things. I think sometimes we just a little lazy about what we do, and we struggle to change. So I have a lot of questions. I'm going to pass it on to some of the fellows and some of our faculty who are joining us to ask some questions. If there's anybody who wants to ask a question, if you raise your hand, I'm going to promote you to panelist so that you can ask their question. Or you can use the chat function. So, the one thing, and I'm glad you mentioned your study, congratulations for taking on this study, because I think that's the one we need, right? Is what do we do after 1 month, right? Well, actually, can we give patients single antiplatelet therapy from the time of their stent? Because now with the new stents, and, we published Onyx 1, we've shown that even in ACS patients, if you do single antiplatelet therapy after 1 month in high bleeding risk patients, they did well. So I'm really interested to see the data of your study. I can't wait to see it. I think that's going to be practice changing because, if we can move to single antiplatelet therapy from the time of stent implantation, I think that's going to be impactful. I did want to ask one thing, though, before I moved on to the fellows and the faculties. One of the challenges we have here in the Bronx is economics. And many times in ACS, I put the patients on DAPT with ticagrelor, and then I get called, a month later or 3 weeks later saying, listen, the patient says, or their PCP says, we can't, the patient's insurance will not pay for it. Can we switch back to Plavix? And I go, of course, I'd much rather you take clopidogrel than nothing. So how do you overcome the economics of prasugrel and ticagrelor in Brazil?
That's a very important question. I mean, the reimbursement system in the country is such that, everybody has to pay for their own pills. So we don't have reimbursement. So this is a major point for us too. This study I have just mentioned to you, Azim, is the budget comes from the government, the Ministry of Health, and they only agree to do that because the patent of prasugrel and clopidogrel and ticagrelor in the country has just finished. So we'll have generic ticagrelor and prasugrel in the near future. I know it's local. It's local reality, but that's something that may happen. I mean, if we help showing that this is a good strategy, we may be able to get that through practice via these. I don't know how much the price of the official ticagrelor and prasugrel will decrease after we have generics in the market, but that's something that certainly will happen. Clopidogrel monotherapy has been used in some of those studies that I've shown to you, but that's coming from Asia. And the Japanese, the Chinese, and the Korean patients, they are a bit different. So most probably we'll have to see in our population, more Western population, how it goes. When it comes to only clopidogrel, no aspirin. I don't have a straight answer for that.
Pedro, before I pass you on, there's a good friend of ours joining us today from Italy, Antonio Mangieri, who's also working in this field. Antonio, do you have any comments or questions?
A lot of questions, a lot of comments. Thank you, Pedro, for this very nice lecture. There's an ongoing debate on primary prevention, aspirin versus clopidogrel. What is your point of view in this setting?
Well, primary prevention is another completely different animal, right? First, you have to define what primary is. If you if you have no symptomatic and you have and if you have an MSCT showing a plaque, is this primary or not? I mean, there's so many questions open to it. The classic definition of primary prevention is something that, to my point of view, I don't know if we have to use aspirin right now. So, I don't know what type of randomized trial we'll need to do to prove that clopidogrel or something else will be good for this type of situation. Is it going to be versus placebo, versus aspirin?
Yeah.
And what do you want to decrease? Is this mortality? Then you're gonna, I mean, you will need, you know, a lot of patients, because the death rate is very low. So my feeling is that we won't be able to see a final conclusion of that question in the near future. And most probably that's coming from, you know, big cohorts coming from clinical practice. I don't know. And there is no randomized trial right now going on. So what's your feeling about that?
Yeah. Now, the problem is that I totally agree with you. The problem is the definition of a high-risk population. I mean, there is a number of definition. People are talking about diabetes, primary prevention based on the features of the CT scan of plaques, carotid artery disease, PAD. So I think there is like a potpourri of definition, which is so it's very difficult for me to define what is a high-risk patient. I have to tell you the truth that in primary prevention, in my practice, I prefer not to give like an antiplatelet, but I prefer to push on statins to reduce the LDL cholesterol, because in most of these studies, what is actually underlined is that in some cases, you can harm the patients instead of giving some benefits, especially in terms of bleeding. And this harm is more pronounced giving aspirin compared to P2Y12 inhibitors. But it's something that is difficult to accept to give like clopidogrel in primary prevention. Sometimes people, the feeling of the people is also a little bit strange. They say, why you don't give aspirin instead of clopidogrel, etc. So I think there's something that we need to explore about that.
Well, I couldn't agree more with you, because I mean, when you give these type of agents, I mean, you never know if you're protecting the patient, but some harm will come. These patients will bleed.
So before I move you on to our live panel here, there's a couple of questions on the QA, Pedro. The first one is from one of our general cardiology fellows, who thanks you for the talk. And he says, what DAPT regimen do you, so outside the clinical study, we always like to ask our speakers what they do in their clinical practice, right? So what do you currently do for your patients in ACS? And how do you individualize for patients deemed to be at higher risk? Just your practice.
Yes. If the patient is at high risk bleeding, we tend to use monotherapy. It's only ACS, right?
Yeah, ACS.
If, on the other hand, if the patient is at very ischemic high risk, left main, very complicated bifurcation, lots of stents, then we tend to give 1 or 3 months DAPT. That's what we are doing right now. Okay.
1 or 3 months DAPT, and then single monotherapy with P2Y12, right? Okay. And then Dr. Khalil, who's one of my partners, asks, and I guess we could extend her question, but she says, does the data on single monotherapy also translate to overlapping stents for long lesions? I would ask, what about complex lesions in general, bifurcations, left main, long stents, overlapping stents?
That's all included. When you look at the global leaders, 16,000 patients, they were all in.
Okay, all comers.
Oh yeah, everything. And for our new mindset study, there is basically no angiographic exclusion criteria, so it's gonna be all in.
Okay, perfect. I'm gonna pass you on to the fellows, and let's start with Sebastian.
Yes, thanks a lot. Can you hear me? Thanks a lot for the great talk, and congratulations on the study. Certainly amazing. I have one question regarding clopidogrel. I mean, you presented a lot of studies, including clopidogrel, but I'd like to know your opinion on whether you think that we should include tests for responsiveness on for clopidogrel, because we know that there's a considerable portion of patients that do not respond to clopidogrel as well as others. Do you think, at least for studies, we should include these tests? What's your take on that?
Well, thanks for the question, Sebastian. It's very appealing, right? I mean, there are 2 types of tests. I mean, you can test genomically or pharmacologically, let's put it this way. Neither has given any positive answer. I mean, there are so many studies on that. I can count at least 10 studies on that, all negative. So as much as we can see right now, I mean, there is no better guidance than clinically eyeballing it.
Samina?
Thank you so much for the fantastic talk. I have 2 questions. The first one is, what is your practice in patients with atrial fibrillation? And the second question is about the trial that is very exciting, the new mindset trial that you explained. In that 96-hour period before randomization, if there is a non-culprit lesion that you're planning to fix, what's your antiplatelet regimen during that period of time in the trial?
Good question. The big open question, I'm going to answer the last question first. There is one large gap of information here, which is the following. I mean, before knowing the anatomy, what do you do in the ER? See, everything that we have seen here is post-PCI. Mm-hmm. So what about when you receive the patient in the ER, what to do? It's a big open question. I mean, so all these patients were on DAPT up to the point of the PCI. So we still have, some days of DAPT after PCI going on, because I mean the agents have some lifespan in their action. So all of them were on DAPT till the end of the percutaneous strategy. If it's staged and you do one or two procedures, they will remain on DAPT up to this point. So aspirin free was after that. Before that, I don't have an answer to you. My feeling is that we'll need a randomized trial, because when you are in the ER, it's very hard to answer your question based only intuition. When you look at the because I mean, you will have patients with no coronary artery disease, you will have patients with MINOCA, you will have patients that will come to the PCI. Some patients will have to do CABG. What to do with these patients? So it's an open question. And what was the other question?
Your practice in atrial fibrillation.
Oh yeah, yeah.
Thank you.
Yeah, right now those patients will stay with clopidogrel and anticoagulant, whatever you want to give.
Immediately post PCI.
Mm-hmm. Mm-hmm.
Thank you.
Thanks, Samina. Pierre?
Yep. Thank you very much, Dr. Limas. Really enjoyed the talk. Just 2 questions. So we've seen in the last years a lot of developments in terms of the devices. So stents, we went from early generation drug-eluting stents, then second generation durable polymers and bioresorbable and polymer-free. How much do you think in 2022 does the technology modify the effect of a short DAPT? And the other question is on designing a randomized trial in this setting. Like master DAPT randomized after 1 month period. I guess there's a whole bunch of implication according to when you decide to randomize in the studies. I was just wondering what do you think about that, and when is to you the best time to randomize?
What we are testing right now is to give no aspirin whatsoever after PCI. The trial is ongoing. We'll see. I can give you some preliminary, if you want, results. Those are not results, but we have already included 2,000 patients. DSMB is very active in our study because of safety, because of the obvious safety concern. We have already had 2 DSMB meetings, and the last one was with 1,400 patients included. And I can tell, I mean, they recommended the study to carry on. So it seems that there is no safety concern, although the trial, of course, is not finished, but so far no safety concern of stopping aspirin just after. We have to finish the study and then see the results. In terms of stents, I mean, we all know stents that we have right now are much better than the early generation stents. My feeling is that I don't know if we're going to be able to improve the stent that we have right now, especially because there is not so much investment on that. And to improve, you have to invest.
Yeah.
And it's frozen now. So, I mean, we are in a good position, but I don't think we're going to change in the near future, because, I mean, what we have is basically, my feeling, what we'll have for the near future. Other technologies may appear. I mean, DCB is something that's coming, not so much in the US, not so much for us in Brazil too, but I can tell, I mean, in Asia, in Japan, they use DCB a lot.
Mm-hmm.
I have some friends in Japan that basically don't use stents anymore. And when it comes to DCB, everything that I've just said to you doesn't apply. And we have to test that.
Yeah.
If this is coming, I wouldn't say for most patients, but for some patients, we'll have to address these issues, because right now DAPT is mandatory after DCB. I mean, DCB staying behind that, because I mean, now if you have DES aspirin free, what about DCB? Because it's supposed to be less thrombogenic. We'll have to see. So I mean, my feeling is that we'll need a trial for that.
Yeah. Well, you know, we just finished this year the first trial with the paclitaxel balloon in restenosis, and on Friday, the FDA just approved the first sirolimus coated balloon trial in ISR, which I'm going to be leading here in the US. But it's so hopefully it'll take a little while, but we'll have it.
Which one is it?
Magic Dutch. It just got approved by the FDA to start the trial. You know, the FDA has not made it easy to do the trial. So just about every single device that you've used in Europe or has been used in Brazil, the FDA has asked for more testing, more animal testing. In some cases, they've asked the company to change the formulation. So it's taken a long time to get approval to even start the trial. So yes, William, that's right. It's Concept Medical who makes Magic Touch. So William's on, and I think it's the William me and you both know, because the questions sound like William questions. I'm gonna. He's got a whole lot of questions for you, Pedro. William asked. He said, Marco Valgimilio, co-PI in the ongoing trial, does functional testing with clopidogrel monotherapy and changes to presical or ticagrelor in case of residual high activity on clopidogrel. That's what he does in his clinical practice. So he asks, what do you think of this, conservative strategy? Because the negative clopidogrel testing trials that you mentioned were all done with aspirin on board.
Mm-hmm. Again, I have a question to that. We'll have to wait for Marco's conclusion on that. But I can tell, I mean, we were talking about practical issues and financial issues. That's gonna complicate life. We'll see.
Right.
We'll see.
Great. He also asked William, maybe you said it, Pedro, is there enough evidence to stop aspirin after a single IV injection prior to the procedure?
Can you say that again? Where is it?
It's in the QA. Is there enough evidence to stop aspirin after a single IV injection prior to the procedure? William, what do you mean by single IV injection?
Yeah.
Maybe he'll type it or he'll tell us.
Well, I don't know if you can hear me, but
we can. Hey, William, we thought it was you.
I'm sorry to interfere. I'm the William the Fellow here. I'm learning. No, it's fantastic.
William
No.
Wise. Oh my God.
No, Pedro, but we are facing a very strong push to stop aspirin, and even during the procedure. And so one practical approach could be you give an IV shot and that's it, and then you start your P2Y12 after the case. But can this be? Is it reasonable to do this already now, outside the context of a trial? I mean,
I think so. And if you look at the new mindset, the study that we are conducting, it's basically what we do. I mean, the difference that we don't do it IV.
okay.
The patient is taking DAPT up to the point of the procedure, so it's protected with aspirin for some time after the procedure.
Yeah.
Then we stop it.
Yeah.
So interesting, William, we don't have IV aspirin here in the United States.
Okay, interesting.
Interesting, yeah.
No, but you have chewing gum.
Probably there's no money to be made in it. That's why we don't have it.
Yeah.
Thank you for joining, William. So there's other questions. We also have a lot of people on, Pedro, because a lot of and I want to welcome the applicants. There's a lot of internal medicine residency applicants who are applying for our cardiology fellowship who joined this morning. So thank you for joining. And Feng Gao, who's one of the applicants, has a question here, and he asks, is there a clear time window after DAPT where bleeding is highest following PCI for ACS? So, and I think it's a really interesting question because we've asked this question before, right? Because we know with, thrombotic events, there's a very high risk within the first 30 days, right? 80% of stent thromboses occur in the first 30 days. And then the rest, the other 20% over the next 11 months. But when it comes to bleeding, is there any data to say the highest risk of bleeding is within the first month or within the first 3 months? Or if I get through the first 3 months, I'm not going to bleed afterwards. What do you think?
With radial approach, the risks of bleeding peri-procedure decreased. There is a burst of bleeding just after the procedure, but after 1 month, the increase in the chances of the increase in the rate of the occurrence of bleeding is steady. I mean, it doesn't plateau.
Yeah.
It keeps going. So there is a burst just after the procedure. With radial approach, it decreases a little bit, but after that, it's steady.
Yeah. We actually published a paper many years ago when I was in Milano showing also the same thing in real world, that the risk just stays the same. It never plateaus. So, because people were saying, if the patient didn't bleed in the first 3 months, they're not going to bleed, right? And that's not true. It's truly a continuous risk that continues and never plateaus as far as we know. Okay, so I think we got, thank you so much for joining, by the way, and for any of the other applicants, if you'd like to ask a question, please do. Andrea Mignatti, who's one of my faculty, one of my partners. I think you had your hand up, Andrea.
Yes, hi, good morning. First of all, thank you very much. It's a great talk, and it's coming up very, very good, great discussion. I had a question for you. It's more of philosophical, if you want to. Like, do you foresee us tailoring the therapy to each individual situation? The guidelines right now, and what we're talking right now, is like a one size fits all, right? We're saying 75 or 81 of aspirin and DAPT at a single dose. But we are really considering the situation we're dealing with is a lot more complicated. There's patient aspects, there's procedure aspect, there's disease aspects. So a type A lesion is very different from a bifurcating left vein. A patient that is 40 years old is definitely different from an 80-year-old with diabetes. So the question I have is, what do you think? So first of all, do you foresee us doing what cancer research is doing, trying to tailor dosing and medication to each specific patient? And second, how would you do it? How would you study something to really extrapolate this data? Like, is there a way? Will we ever be able to give a different medication, different dosing to different patients?
I'm going to add to that, Andrea. I treated a patient last week who was in chronic kidney disease, right? He was 180 kilograms with a BMI of 50. And I put long overlapping stents into his LAD after doing rotablation and shockwave, very calcified lesions. And so I put him on ticagrelor, right? Because I figured with his weight, the high BMI, the complexity, I wanted him to have a more potent antiplatelet therapy. But then I got called 2 weeks later by his doctor saying, listen, his insurance will not pay for it. Can we switch him to clopidogrel? And me and her were talking, and I was saying, but what's the right dose of clopidogrel for this patient? I mean, how can I give someone who's 180 kilograms just 75 milligrams of clopidogrel, which is the same dose I give to someone who's 50 kilograms, right? But you got to look in the literature, and the data is really limited on how we tailor dosing. I'd love to hear your comments, Pedro.
Well, Andrea, and philosophically, as you said in the beginning of your question, I would love to see it. All this concept about precision medicine, I mean, it's coming to stay. It's applied in oncology. It hasn't contaminated cardiology that much yet, but it's coming. I don't know exactly how to do it, because I mean, you can test people genetically. You can test in terms of the pharmacological effects, in terms of the antiplatelet effect. The ischemic risk, very hard to assess. We don't have a good tool. Especially because there are two types of ischemic risk, my point of view. First, high risk of having thrombosis or whatever, and high risk of having a bad complication if thrombosis occur. Those are two different things. See, I mean, having a thrombotic left main stent is not good, regardless. So my feeling is that we'll have to attack that, but we don't have good tools for none of those things that I've just mentioned to you. The way we do right now, I mean, one size fits all. Here and there, you have, one patient with 150 kilos, and you don't know what to do. And but that's something that we'll have to do. That's my feeling. I mean, we'll have to leave the realm that we are living right now, which is one. And in cardiology, we are lucky because we have numbers to derive. I mean, some other specialties, they're not as lucky as we are, because they don't have, epidemiologically, they don't have as many patients as we have. So, I mean, my feeling is that we'll have, it's our duty to do that, to develop this field.
Yeah. But I'm sure you're tiring out, but we've got two more questions, if you don't mind, or two more colleagues are going to ask a question. Manav, and then Andrea.
Thank you, Pedro. That was incredibly stimulating, and congratulations, and thank you for taking the initiative to do your P2Y12 monotherapy study. I think that's very exciting. I was struck by the in vitro data you have that shows the very little additive effect that aspirin has on top of P2Y12. I would think that it's maybe not that difficult to do a study where we check platelet reactivity in patients and see if we can simulate that. So I'm wondering if you knew of anybody or any data that looked at this in vitro to see if that effect is the same. And then my other question is kind of similar to a previous question that was asked about patients with indication for oral anticoagulation. Is there a time period in those patients who've gotten prior stents where you think you can stop antiplatelets altogether and leave them on anticoagulation, oral anticoagulation alone? There is a consensus statement from the American College of Cardiology that recommends this after a year in patients with prior PCI, but there is a lot of hesitation from people to stop antiplatelets altogether. So wondering about your input on that.
Yeah, and right now we don't have the courage to stop antiplatelet at all. And one size fits all again, anticoagulant plus clopidogrel for all patients. That's what we do. If the patient is very high ischemic risk, then we give 1 or 3 months of aspirin together with clopidogrel, but not ticagrelor or prasugrel with anticoagulant. again, an open question. If you want to do a trial on that, welcome, because that's gonna be a hit. And the other question was?
Anybody do like platelet reactivity testing to look at the additive effect of aspirin in real patients?
Not to my knowledge, not on routine basis, no.
Not routine basis, but I'd just be curious about the proof of concept, because it was, again, so striking to see the in vitro data that there's such little additive effect of aspirin. But I think
very much, yes.
Yeah, that's a really that was a really striking set of data that you showed that I think hopefully pans out in your trial. So best of luck. Thank you again.
Thank you.
Andrea, did you have any questions?
Yeah, sure. Thank you for your talk. It's interesting to see that all of us have very similar questions, because as physicians, we see patients, we want to know what to do with each one of them. My question is, what do you do for the sicker patients? Because they often have both a high ischemic and also bleeding risk. So which kind of therapy do you use in those cases?
Then it's gonna be really a case-by-case type of assessment. In the COVID time, we had these patients very often. I mean, patients that had ischemic complications plus bleeding at the same time. What to do with those patients? I mean, we went case by case. I mean, I think I can figure one single answer for such a diversity of clinical situations.
Pedro, before I go, we're going to end with William's question as the last question. Before I do, are you using Cangrelor in Brazil, or is it too expensive?
We don't have that. We don't
have it? Okay. Okay. So William asked, we're talking about events and so on. He says, typically Mason stent thrombosis may not be sensitive or frequent enough to show an increased risk of microthrombi during the procedure. The right endpoint could be high sensitive troponins for identification of minor myocardial damage, not just the full-blown MI. What do you think? Are you going to include periprocedural troponins in your ongoing monotherapy trial?
We did not. After thinking a lot about that, we have not included as an endpoint. I mean, we are collecting data, but that's not an endpoint. The endpoint was, as William said, full-blown MI, because those are the events that have any prognostic impact. So we are measuring that. Everything is collected, but the endpoint is a pre-procedure MI with capital letters.
Yeah. The other problem also with periprocedural troponin, it also takes into account, the procedure, the complexity, post-dilatation, rotor. There's so many other factors that can affect it. I guess because it's randomized, it gets balanced, but it also creates a lot of noise when you look at that endpoint.
Very much. And the standardization of kits across hospitals, we're talking about
45 hospitals, all doing the same high sensitivity troponin I with the same kit. Yeah, it's very difficult to compare. Great. Thank you so much, Pedro. This was great, and the discussion was phenomenal. Thank you to the faculty and fellows for making it so lively, the discussion. I learned so much from your talk, but I also learned from all the great questions that the faculty and fellows had afterwards. So thank you for your time. William, thank you so much for joining. Always great to have you as part of these discussions.
Very much.
Take care, everybody. Have a good day.